Colleagues, thank you very much in the beginning for having me for this very interesting webinar. It's a great honor to be here and to talk to you about the guidelines that nowadays we have for thermal ablation in both benign and malignant thyroid nodules. I am Dr. Mauri. I'm working in Milan at the European Institute of Oncology, performing thermal ablation in different clinical scenarios from renal to liver to lung ablations. And also I'm dedicated to the treatment of thyroid diseases. So, as a background, we have to acknowledge that probably still at the present, there are too many thyroidectomies that are still performed in several countries for benign thyroid nodule. I will talk to you initially on benign condition and then on the malignant one. If you see from this table, still a very large number of patients every year undergo surgery for thyroid diseases, and a different rate going from 30% in Italy to close to 60% in France are treated for benign conditions. So the numbers where we can start to have an impact are very, very large, because if not all, as for sure, a majority of those cases can be managed in a more conservative way than surgery. Better understand the aspect of minimally invasive techniques in thyroid nodular disease. In 2019, the European Thyroid Association had a survey among their participants. So a survey was sent to all the members through Europe to understand how they approach minimally invasive treatments of the thyroid. And in this survey, some different scenarios were presented. For example, it was presented a case of a 50-year-old female with a 4 centimeter spongiform nodules, Euthyroid 2 with a benign fine needle aspiration with symptoms of compression. And following an identical case, but in a patient of 75-year-old with severe comorbidities like diabetes, cardiovascular disease, and renal failure. How did the participant answer? In the first case, 60% requested surgery, and only 70% suggested radiofrequency, and 8% laser, means a thermal ablation. While the scenario completely changed in the case of older patients, for example, for the case of the 75-year-old male, where the majority, but still only 1/3 of the participants recommended thermal ablation. So there is some idea that this kind of procedure can be offered, but still particularly in very complex patients when surgery is not feasible. Also, again, other two scenarios of a patient with malignant thyroid disease, again, 75-year-old female or 25-year-old female with thyroidectomy and lateral and central compartment neck dissection, and afterward local non-radioiodine avid lymph node metastasis. You see in the old case of the 75-year-old female, still 55% of participants requested surgery as first treatment option, while in the case of the young one, surgery was requested in a lower number of patients, and ablation had a higher percentage of responders. So again, quite a variable scenarios. But particularly, one point that came to the attention was that in close to 70% of cases, the responders never or rarely refer patient to center with specific expertise in thermal ablation. But if they do not have in their hospital this kind of expertise, they do not suggest thermal ablation. And this is quite strange from one side, but determine us to try to understand a little bit better why so many endocrinologists did not consider thermal ablation. And the reason why physicians never or rarely refer patients to ultrasound-guided procedure, minimally invasive treatments, was in the majority of cases because there were no endocrine society guideline on the use of minimally invasive treatments. So in some way, endocrinologists were scared about referring a patient to a procedure that was not included into a guideline. That's why in the 2020, the European Thyroid Association published the first clinical practice guideline to the use of thermal ablation in benign thyroid nodules. And also this year, we, together also with the Cardiovascular Interventional Society of Europe, performed an analysis and published the clinical practice guideline for the use of minimally invasive treatments in malignant thyroid lesions. So at the present, we have two guidelines, one for benign and one for malignant. So this should be the basis for enlarging the application of minimally invasive treatments in patients with thyroid nodules. However, we should acknowledge that guidelines are not enough and sometimes might not be only an angel, but may determine relevant problems for physicians that can feel compelled to decide for some procedure instead of others. So the main purposes of clinical guidelines are to describe the appropriate care based on the best available scientific evidence and a broad consensus, trying to reduce the inappropriate variation in the clinical practice for a more rational basis for referral, focus for continued education to promote efficient use of the resources, which are also always limited, to act as a focus for quality control, including audit, and to highlight shortcomings of existing literature and suggest appropriate future research. However, it is known that from the publication of guidelines, there's always some barriers to their implementation in the clinical activity because there are general resistances to changes. They are seen sometimes as a loss of professional autonomy, and sometimes there's also inadequate skill set and lack of decision to support technology. Often they are out of date because when they are published are based on old literature, and the current practice is changing while the guidelines are published. Also, we should always remember that the value judgment made by a guideline development group might be the wrong choice for individual patients. So again, always remember that guidelines provide us with a guide, but not with a strict indication on what really we should do. It's something that we have to take into consideration. So let's start from the guidelines on benign thyroid nodules published in 2020 by this group of authors. As a background, we should just briefly remember that there are papers like this meta-analysis that I coordinated and we published in 2020, showing how thermal ablation are able to provide long-lasting results, both radiofrequency and laser, with sustained results over at least 3 years. So we have a robust meta-analysis that provide us good results. And also another paper of the Italian multidisciplinary group for the study of minimally invasive treatments published by my colleague, Dr. Bernardi, which I had the pleasure to coordinate, and showing how the results are sustained at 5 years with very good results, but highlighting how in some cases there might be a regrowth of the nodule. So this is something that we should always take into consideration when thinking about proposing this kind of treatment to our patient, because we have to take care of the idea that 1/3 of cases sometimes might have a regrowth of the nodule. A systematic literature review was performed, and in both guidelines, a grading of quality of evidence was performed, going from very low to moderate, or high, and a level of recommendation was divided into 2 levels: strong or weak. So in all the recommendation, you will see a grade of evidence and a level of recommendation. The first recommendations state that in adult patients with benign thyroid nodules that cause pressure symptoms, remember, we have to treat symptomatic nodules, or cosmetic concerns, and decline surgery, image-guided thermal ablation or minimally invasive treatment should be considered as a cost and effective alternative option to surgical treatment or observation. So still in this guideline, it is suggested that the patient should be not candidate to surgery or decline surgery. I would just like to point out that in our national guidelines, we instead stated that thermal ablation may be proposed as a first-line treatment for solid non-functioning thyroid nodules. So actually, we are moving a little bit from the option to apply this treatment only in patients not suitable for surgery to a real alternative to surgery, offering this treatment as a first-line treatment. I'm not going to read you all the recommendations that you can easily find in the paper, but I just would like to show you the one that I think are most interesting also for potential later debate. So the third recommendation, remember that before ablation of a thyroid lesion, a benign cytological diagnosis is needed. It is suggested to repeat an FNA for cytological benign nodules, with the exception of spongiform nodules and purely cystic nodules. So nodules with very clear ultrasound features of malignity. Also, there's a strong recommendation against performing minimally invasive treatment for those nodules that present with high risk ultrasound features. So if you have a suspect on ultrasound, even in the presence of a benign FNA, do not perform thermal ablation. The sixth recommendation states that local subcutaneous and pericapsular anesthesia is recommended. It is possible also not to perform local anesthesia, for example, when performing laser, but still it is recommended. Conscious sedation can be used and can be considered, so it is the choice of the operator. It's not obligatory to do mild conscious sedation, but can be used. Coming to the eighth is about the suggestion for the evaluation after treatment. So an early term in 2 to 3 months, mid-term 6 and 12 months, and then every 1 to 2 years ultrasound evaluation is recommended. At 12, recommendation state that in multinodular goiter, due to the present lack of evidence of efficacy, and particularly for the need of repeated treatment that can occur in a not negligible number of cases, thermal ablation should be restricted to those patients with a very well-defined dominant nodule in the setting of the multinodular goiter, or those who are not candidate for thyroid surgery or radioiodide treatment as a palliative therapy option. So at the moment, multinodular goiter is still not our ideal field of application. Another recommendation, 13 recommendation, state that because of a higher cost and complexity as compared with aspiration and ethanol ablation, at the present thermal ablation are not recommended as first-line treatment for pure or predominantly cystic thyroid lesions. Again, strong recommendation. It means that in the presence of cystic lesion, still ethanol ablation is the first option of treatment because it is cheaper and easier to be performed. Also, thermal ablation should be considered in a young patient with small autonomously functioning thyroid nodule, and particularly in those cases with small nodules and incomplete suppression of the perinodular thyroid tissue, due to the higher probability of normalization of the thyroid function and the advantage of avoiding irradiation and restricting the risk of late hypothyroidism. These were the recommendations for benign nodule. Let's see a clinical case of a patient with a malignant one. Is a female with 6 millimeter hypoechoic irregular nodule. Here you can see the images, where once detected, we decide to perform FNA. There should be debated if with such a small nodule FNA should have been performed, but we found a small papillary thyroid cancer. And so once we have detected a small papillary thyroid cancer, we really would want to propose our patient not to do nothing, or we want to move the patient directly to surgery, or why not to propose image-guided ablation? Once we have overdiagnosed a very small nodule, we have seen this with ultrasound, performed FNA, found a cancer. Why we cannot try to minimize the invasiveness of treatment? That's what we do. And in our patient, we propose at our institution always the three options. We recently published our preliminary results with quite a small series of patients, but what I would like to point out is that all the patients that were feasible, in which ablation was feasible, agreed and were very happy of having this option. Coming through the guideline, we stated as the first recommendation that it is necessary to take into consideration the use of minimally invasive treatments in the multimodal approach to patient with thyroid cancer. So when you deal with a patient with thyroid cancer, a multidisciplinary discussion should take place, and image-guided ablation should be among the panel of available options. How to balance between minimally invasive treatments or surgery? In the paper are also reported some factors favoring surgery or favoring thermal ablation. For example, the age, the familiar history of aggressive form of thyroid cancer, then the refusal of surgery, and also the presence of expertise of both thyroid surgery and ultrasound-guided procedures. Then a multidisciplinary team, including members with specific expertise in minimally invasive treatments, should perform the selection of patients eligible for minimally invasive treatment based on the patient's clinical, demographic, and imaging characteristics. Regarding the modality to be chosen for minimally invasive treatment, this should be selected on the basis of the staging of disease, patient characteristics and preferences, and also specific competencies and resources at the treating centers. So there is not a clear rule for using microwaves, for using radio frequency or laser, but it really depends on the case by case, on patient characteristics, but also by the experience of the operator and the availability of the material. It means that if you are very good in microwave ablation, go with microwave ablation for thyroid nodule. But also, it is strongly recommended always to inform the patient about the feasibility of minimally invasive treatment, its advantages and limitations in comparison with other strategies. This means that when you face this kind of patient, you cannot anymore, do not tell them anything about this option. Patients should be informed about the presence of minimally invasive treatments. That can be also considered for palliative purposes, but only for palliative purposes in a context of a multidisciplinary approach in patients with other kind of primary thyroid cancer other than low-risk PTNC. And here the strength of recommendation is lower. This is really only for palliative purposes. What about recurrences? We know that recurrences might occur in a not negligible number of cases and might be highly disabling for patients, where second surgery might be extremely challenging for the possible side effects and should be always carefully weighted against the risk of treatment failure. Also, most recurrences are not clearly aggressive, and patient is worried and sometimes but patient prefer clearance of the disease. So again, might we have any kind of role in lowering the invasiveness of treatment by providing an effective cure for patients? And here we stated to consider minimally invasive treatment as an alternative option to surgical neck dissection in patients with radioiodine refractory cervical recurrences who are at surgical risk or decline further surgery. So again, in these cases, this is an option that should be taken into consideration, but only in cases not suitable or refusing surgery and that cannot be managed by radioiodine ablation. Here also, there are some factors that can be in favor of thermal ablation and other that can favor surgery. If you have an old patient with relevant comorbidities, previous neck dissection, with a feasible ablation, so with limited number of metastases and ideally small metastases, and you have an easy percutaneous access, so ablation can be the ideal option for this patient. In the other option, if you have a very young patient with no comorbidities, acceptance of surgeries, multiple metastases or larger one, and with a good long-term prognosis, so still surgery might be the ideal option for these patients. Just let me conclude showing you a case of a patient with a lymph node, a metastatic lymph node from papillary thyroid cancer. You see a single lesion, quite small, quite easy to be reached in a percutaneous way. The patient was already treated with 2 neck dissections, so she really refused to have another surgery. We performed percutaneous ablation. You see the gas forming during the treatment. We always perform CUS after the treatment to evaluate the presence of uptake or the complete devascularization of the lesion. And here you can see the result, where we have the pre-ablation PET CT scan and 12 months after the complete absence of uptake at that level. So a complete treatment with very, very minimally invasiveness. So coming to conclusion, we can state that in adult patient with benign thyroid nodule that cause pressure symptoms, always remember that we are treating the symptoms of the patient, not the nodule. In these cases, thermal ablation should be considered as an alternative option to surgery. And now we have guidelines that state us that we should consider this. We are no more allowed not to tell the patient that this option exists. Even if this is not available in our hospital, we have to tell this to the patient and eventually to refer the patient to another center. Also, these procedures can be suggested in patients with autonomous functioning nodule, particularly if they are small, when the results are really better, and an incomplete suppression of the perinodular tissue is present. Because in these cases, there's a higher probability of thyroid function normalization and the absence of late hypothyroidism that can be conversely deriving from a radioiodine ablation. The choice of surgery or thermal ablation should be the result of a careful balance between the nodule characteristics, general clinical conditions, available resources, and the patient's value and preferences. Regarding malignant diseases, consider the using of thermal ablation for patients with low risk papillary thyroid microcarcinoma, particularly if the patient is at surgical risk, is expected to have short life expectancy, or is unwilling to undergo surgery or active surveillance. Often patients do not really like active surveillance once we have diagnosed a cancer, but on the other hand are scared about major surgery. Also, thermal ablation can be considered as an alternative to surgical neck dissection in those patients with radioiodine refractory recurrences, again, in cases at high surgical risk or in patients who decline further surgery. So we have nowadays two guidelines, one for benign, one for malignant conditions, that can guide our practice toward a larger application of thermal ablation in patients with thyroid diseases. And so thanks to those two papers, I think and I hope the number of procedures that we will be able to perform will increase significantly in the next years. And with this, I would like to thank you for your attention, hoping to having provided you a clear enough overview of the present guidelines. And thank you very much for your attention.
Okay, so thank you.